All right, well, we're ready to get started with the next session, so thanks very much for the keynote. Phenomenal lecture, and I enjoyed the Latin reminders from grade school. So my name is Naveen Kapoor, and I'll be co-moderating this session with Susanna Price, so thanks, Susanna, for joining me. And this is the session called Science at the Cutting Edge, ECLS and Beyond. So Susanna, if you want to do the first introduction.
So it's a great pleasure to be here. It's fantastic to see people face to face. It's not going to be Don Hill speaking to you as a first presenter, I'm afraid. We've got a substitute in the name of Bob Bartlett. So Bob, the floor's yours.
Hello to all, and let me also say how great it is to see all of us in the same room meeting in person once again, as we've done over the years. Thank you, Derek, for a marvelous, very thorough literature review and a glance forward. I will just talk a minute about looking back several years, which is what Don Hill was going to talk to us about. And Derek outlined the elegant review of ARDS trials, and of course, as you all know, during that same time, the neonatal and pediatric trials unequivocally proved that it was of value, so it became standard practice for many years. And much of that is based on the very first neonatal ECMO patient. It was in 1975. Many of you know her because you've read the paper called Esperanza, and I'm pleased to tell you that she's here today to say hello. Esperanza. A dear friend of 48 years, amazing. Don Hill was going to be here, and he was going to tell you about the very first adult ECMO case. Happened to be an ARDS case. We were not called that at the time, but now we know it is. And unfortunately, he was really wanted to be here. He was very excited about this because this year is the 50th anniversary of the publication of that patient, a single case report which led to development of ECMO for ARDS, and you've heard how that played out over the next 50 years over time, that we're still working on it. A couple days ago, Don called me and said, I can't come, I'm really sick. He's in San Francisco. I don't feel safe in getting on an airplane. So sadly, I'm going to give his talk, which he'd prepared very nicely. However, his wife and his two sons, his sons are students at Boston University. They're right here. So I would like to introduce Jing Hill. Where is she? There we go. Don's wife and his two twin boys, Ping and Ming Hill. Please say it. So a bit of a look back. So I'm just going to present what Don had prepared with just a few minor comments along the way. So we invited him here to talk about the 50th anniversary of this really important publication, which was published in the New England Journal in 1972. The case was in 1971. Worked good. So he began with a discussion about cardiac surgery. Few people in the audience will remember this, let alone be around then, but the first case on cardiopulmonary bypass was done by John Gibbon in 1953, and a very few surgeons around the world shown here thought we need to learn about this and learn how to do it. Not many places doing cardiac surgery, but of course you know how it's grown over time. And one of those centers was California Pacific Medical Center. It was at the time the headquarters of Stanford Medical School, which subsequently moved south a while, but it was the cardiac surgery program was headed by Frank Gerbode, who you see here working with a cardiologist, John Osborne, and they recruited an engineer named Maury Bramson, assigned him the job of building a membrane oxygenator, because in the 60s, most of us knew that the heart-lung machine was a lethal instrument if you used it for more than an hour. But we thought if you could just replace the lung part of it, which is raw oxygen exposed to blood, it might work longer than that. So they got working on this in a few centers around the country. And this is Don's description of this, but it's exactly right. Meanwhile, in the 1960s, in basement labs, in some hospitals and some institutions, a few very young, intrepid people were working on the idea of extending cardiopulmonary bypass for more than an hour. The idea is if you could get to 3 or 4 hours or a day, wouldn't that be great? And they're literally all shown here. Warren Zapol, you already heard about, working with Ted Colabo, Phil Drinker and I working here in Boston, Maury Ramson and Don Hill in San Francisco, Arnie Landay at Minneapolis at the time, and Pierre Galetti, a wonderful guy at Brown University, and Converse Pierce. So what I'm going to tell you spun out of these few people who had this idea in the 60s. Now cut to a single case. I loved hearing about the case that made you think, okay, this guy was dead, now he's alive, I'm an ECMO believer, now I got to figure it out. So this is a patient who was a young man, 24 years old, motor vehicle accident in Santa Barbara, California. And when he arrives in the hospital, he's alert and awake, he's in a lot of pain, he's hypotensive, hypovolemic, bleeding, and so on and so forth. And as you might imagine, he had a lot of injuries, a lot of fractures, pelvic fractures, leg fractures, but most importantly, a contained rupture of his proximal thoracic aorta. Nowadays, we might handle this differently, but at the time, you operated on that patient with the hope that it wouldn't rupture and they would exsanguinate on the spot. So that's what the surgeon did. The surgeon was a guy named Tom O'Brien, who, as Don says, never gets the appropriate credit for this. So he's a good surgeon. And he's at Santa Barbara Cottage Hospital. Sounds diminutive, and it is, a little community hospital in Santa Barbara. And Tom was a great guy, and he was taking care of this patient and took care of him remarkably well, but he's getting sicker and sicker. Look here's his x-ray, but here's day 4. His PO2 is 45 millimeters of mercury. He's on 100% oxygen. He's on 5 a PEEP. That was new stuff, even trying PEEP. And his peak airway pressure is 60. And with any luck, you could modify your ventilator to get pressure up to 80. That was the idea. Ought to be good. But limping along, 4 days into it, he's making no headway. On day 5, he's even worse. His PO2 is 30. He's on 8 a PEEP. Oh my God. And he's clearly, and he's dying. So what happened on day 5 was Tom O'Brien, as it turns out, was a resident buddy of mine. We were residents together at the Children's Hospital in Boston in the mid-60s, and he knew that Phil Drinker and I were working on a membrane oxygenator, and we had shown that you could put an animal on for 5 days way back then. So we kept working on this. So we were about 100 miles away in Irvine, California. So Tom called me up and said, "Are you guys ready to try that machine yet?" And I said, "No, we're almost ready, but not quite." But Don Hill is a friend. He's done about 6 cases. He's 100 miles away in San Francisco. Let's give him a call. So we did. And then that led to the day 6 VA ECMO institution. Don and Maury Bramson came down to Santa Barbara and set up Bramson's oxygenator, which I'll show you in a minute, and put this patient on femoral VA bypass. And nowadays you're saying, why didn't they use VV? We didn't know about it, so it was all VA. And put this patient on. My partner, Al Gazzani, and I drove up from Irvine, and we spent the next couple of days looking at this patient and this phenomenon that we've been dreaming about. And this is, in fact, Don tells me it's the only photograph of this particular case. I took this picture, so it tells you the timing. But here's the patient, but here's a Bramson membrane oxygenator. You can see it took about 6 hours to assemble a sheet of membrane and a spacer and a sheet of membrane and a spacer, and it leaked and it didn't work, but it worked well enough to provide adequate gas exchange, especially on VA support. So that went on for about 3 days. Patient recovered, got better, and ultimately survived. And here is data. He was confused, then he woke up. He was in the hospital for quite a long time, cleared that up, and eventually went home. And a year later, he had good pulmonary function, and the rest of his parameters were normal. So that was the first successful ECMO patient. This is the first one ever, mind you. So we all thought that was important. So we encouraged Don to write it up, and he did. He wrote it up and published it. This is the Pacific Medical Center team, by the way, Frank Bergotti, who was running it, John Osborne, Don, and Maury Bramson, and Don what he would be telling you at this point is all about the team phenomenon. You get the right people together, doing things together, thinking together, and that's what makes anything complicated work, including ECMO. So this case was published in the New England Journal in 1972, and it's an elegant paper. You should read it. It's fun to read all these details, especially now, looking back as to what was done at that time. Not a lot different from what you're all doing every day. And Don asked me to tell you, he'll send you this paper if you call him on email. There's his number, but you can also find it in PubMed. You don't have to bother Don, but it's a great paper. So what he wanted us all to learn was, it's a single case. It was what was called shock lung at the time. And here's a patient who looked like he was dying of it and recovered. And thanks to all of you for joining in this celebration. So thanks to Don, thanks to the family, thanks very much.
Great, thanks for that. That was a phenomenal case, and seeing that oxygenator, certainly humbling to see where we are today. So the next speaker is Roberto LaRusso, who's a full professor of cardiac surgery in ECLS, coming from Maastricht University Medical Center, Cardiovascular Research Institute in Maastricht. So Roberto.
Thank you. Thank you all. This is a really great honor and privilege for me being here with all these friends and colleagues. So thanks also for this invitation. So these are my disclosures. So anytime I'm being invited to give some kind of these lectures, I want to always pay a personal tribute. And I hope you know this guy because you are all using his technique. And I think this guy really deserves a lot of recognition. And as you know, Seldinger is our really daily practice. And I think he should have really deserved a Nobel Prize for that, because it's not only in cardiology or surgery or whatever. But I think we really need, again, to pay a tribute to another guy that you all know very well. And I think also this guy really would deserve a Nobel Prize. I think. For all the patients who really were treated and survived. And I think that we really need to pay a tribute to Bob. So, having said that, when I started my career, as you can see from my few hairs and why the ECLS statement was, well, ECLS is just put into cannula and then pray. That was a statement. I was trained this way. Well, I think it's a little bit different nowadays. These are the new perspectives. I don't want you to go through because I'm going to present really each one of them, and you will find all these in the new Red Book, and I would like to really thank all the contributors, particularly Graham and McLaren, for his leadership in this very, very fantastic adventure. So I really want to tell you that this is a new adventure. So this is really a new era for ECLS in the future. And this is the telescope from NASA, and we now see the universe in a different way. And I think nowadays, this era is the time for new perspective also for ECLS. So what is now the time for what, I would say? Well, why we need more ECLS? Why we need to do something more? Well, I show you something. This was the year 2000. Look, the GASTO trial, the most important trial on cardiogenic shock. And the results were quite disappointing. And the editor-in-chief of the European Heart Journal, you see, said a more cardiogenic shock, a more aggressive approach is warranted. Year 2000, 22 years ago. Well, let's see about this other study, big study. This was 2012. Well, again, you can see fatality rate very high, 60%. And the conclusion was, again, look, we are disappointed. We should do more. We should be more aggressive. Well, I think that now the latest data in 2018 show clearly the cardiogenic shock is going up and up and up. But look at the, amount of mechanical circulatory support, which is at the bottom line. There's no change. There's no change. And this is also another study showing the temporal trend and the use of mechanical circulatory support in cardiogenic shock. And you look at the mortality and look at the use of MCS. Nothing changed during, well, this is 2017. But I think this is really something which warrants a change in action. And this is a new, very recent paper, again discussing the new concept, the new development in the cardiogenic shock. And I think we have to bear in mind a few items, few really points, very important points. We are going to treat more and more complex patients, more elderly patients, emergency cases, a lot of comorbidities, and we need to have a multidisciplinary team for that. And we have more transcatheter procedure, but this means that we are going to treat a lot of inoperable patients, and I think we are going to expand indications. We have Susanna Price here, and this is part of also her work. The European Society of Cardiology is moving very much into this. And this is just to give you an example how the topic is very important for the European Society of Cardiology, and handbook, and also new expert consensus guidelines. So this means that finally something is moving in the cardiological and, I think, cardiosurgery communities. And I think this is a new classification of acute heart failure. You can see it's no more in a NIA class or whatever, but it's about the SCAI classification. And you can clearly see that the ECLS could really find its role in this new classification. But what is important is timing. This is an editorial and gives you exactly the concept that we have really to run and really do that in a timely way. And I think this, I like very much this editorial because it gives you an idea. We all know, I mean, you have to treat the patient in the right place, with the right time, with the right tool. And I think we are really lucky that we have these tools. So we wrote this interim guidelines, and you can find why this is going to be really important, because the indications are expanding. So the ECLS application is going to be important in many settings. And what about post-cardiotomy? I'm a cardiac surgeon, and this is quite the bad news part. And I think that the results are quite still disappointing. But why? Because the cardiac surgery patient is an even more complex patient. It's really a patient of its own. So a lot of bad, dread things, a lot of comorbidities, a lot of myocardial injury, and so forth. And we recently made this expert consensus paper. Really, it was a fantastic job with the Force Society, and I think this is also something like an effort towards, at least an effort to improve the results, which are still disappointing. And soon you will find an ELSO monograph on this topic, and I really suggest this to all of you, at least for the ones involved in cardiac surgery. But look at the trends in cardiac surgery. Really nice paper with Vala Bayosula, more than 130,000 admissions for post-cardiotomy shock. And more than 50% of these patients require mechanical circulatory support. But look at the trend. Again, the cases are rising, but the use of mechanical circulatory support still stable, no increase in the latest years. And if you look at the two graphs that I showed you before, cardiogenic shock and post-cardiotomy shock, they are the same. So again, we need an action even in this setting. And I like very much, Jonathan is here, I like so much this editorial because we really need to implant the ECLS in the due time, in the timely fashion. And the importance of shock team now is getting more and more important. This is a very nice paper about the Detroit Cardiogenic Shock Initiative. It is clear that once you establish a structure, let's say, approach to the problem, the results are much better. And this is going to be a very, very important topic for the future, and particularly with the use of temporary mechanical circulatory support in these patients. And then we have the bad part. We know complications, but also the technology. This comes again from the paper of the European Society of Cardiology, and we all know these figures. We all know that the more the ECLS is in place, the more the patient is exposed to the risk of complications. But I think we have now a new era. We have new cannulas, we have new pumps, we have new oxygenators coming to the market. We have new devices, and particularly the combination of devices like extracorporeal support and transaortic device. We have maybe also new drugs and new management. We have integration between treatment and diagnostic. This will be another very important aspect in the future because we have a machine in contact with the blood flow. We need to have more information from the patient. And I think we have really to make improvement in monitoring these patients. So new configuration and management. I think in the future, the famous statement at the beginning, 2 cannulas and then pray, is completely changing. We have now hybrid ECMO, and we are going to handle something that in the past, it was really a sort of nightmare for a lot of people, so right ventricular failure. We have now a lot of possibility. Pulmonary artery cannulation gives us a lot of new options and new hopes. And you can see now between cannulas and devices, we can really treat the patient in a direct way, in a, let's say, etiology and disease-directed management. So a lot of improvement. And also the way we are dealing with the patient for the future. Is a transition going to be needed? Well, you know you can use different configuration because the patient can go from ECLS to more durable devices. And I think this was a very nice paper recently about the transition and the predictors for this successful transition or bridge to more durable devices. So again, in this will be a lot of new development. And also the way we are dealing with the ECLS configuration and the use of Hoffman clamp to adjust the flow to more complex, again, ECLS configuration. Again, all these things are changing. There are no more 2 cannulas, but there are more patient-directed management. And I think another very important aspect is a awake patient. This is Kasia. And I think this is going to be more and more used in the future. In the past, it was quite a sort of a nightmare, awakening a patient in the VA ECMO. Now it's really a reality. And the research, this is also very important. We have ongoing a lot of studies, randomized studies, and you know very well about the use of ECLS in cardiac arrest. And we are now also, we finish also our study in mastering the multi-center trial, and the paper now is under review. And we have also other studies in post-cardiotomy, but I think what is really important And we have the treasure of the ELSO registry. This is going, again, for the future, giving us a lot of important information. And to go at the end of the talk, I think that this is a little bit another aspect which we know is under controversial discussion all the time. I think that this is something that is going to be more and more used in the future. I think that we have a lot of pros and cons, but at the end, I think that we know that this should be done at the very beginning of the ECMO implantation. That could be done in a non-invasive way, or we can do it with catheters, devices, cannulas, but I think this is going to be also the future for every VA ECMO patient. And we have to do more studies. These are preclinical studies we've done with a Prague group, and I think these are very important to give more knowledge about this setting. So, in conclusion, I think that this was, again, going back to my beginning, to the beginning of my career, a little bit and the history. But, you know, the transition from cannulation to complication is really subtle and narrow. And I think in the past, this was a little bit the reason for some skepticism about the clinical and non-clinical community. But I think this is not true. And I think absolutely that now it's a new era. Again, we look in a different way, like the telescope of NASA in the universe. I think that now it's time to trust, not to be skeptical, not to be pessimistic, but to trust and further invest in technology. And I think that we know that we need to increase our knowledge, our training, and responsible expertise, of course. I think the next 10 years definitely will be the era of mechanical circulatory support and respiratory support, as unfortunately we tested in the last 2 years. And I think, again, research and relationship with the companies and medical and non-medical professionals will be really important for a multidisciplinary approach. And this will help the welcome to the machine, because we need really to work together. Thank you for your attention.
So thanks very much, Roberto. That was a fantastic presentation. So now it's my pleasure to introduce a great friend and colleague, the awesome Peter Alexander. She is a pediatric cardiologist. She and I had the pleasure of locking horns in a debate in Hobart, Tasmania in the pre-pandemic world. So you're going to tell us apparently pediatric ECMO research and trials. Thanks, Peter.
Good afternoon, everyone, and welcome. These are not my slides. This is not a pediatric talk. And so we've got two options. I don't know if we can flip the slides over. Thank you. I'm happy to wing it a little bit, but thank you for the introduction, Susanna. We did have a fantastic time in Tasmania, but it was well before the pandemic. It's not there yet, I don't think. I can start my introduction while we're waiting for the first slide to come. It's an absolute honour to be invited to be presenting this talk at the opening session of the first in-person meeting for the last few years. This is actually the end of my tenure as the co-chair of PediECMO, which is the small now pediatric network within the ELSO community. And just looking out at all of you here, it's quite remarkable how much it's grown in the last 2 years. So as I'm presenting this slide, these are my disclosures, but the unspoken is that I am presenting on behalf of an enormous community of committed clinicians, scientists, investigators, and collaborators. And many of the slides that I'll be presenting are not my own. All blame to me for the details that I get wrong, but all credit to the investigators on the slides. So as we do think about pediatric ECMO over the last couple of years, we have been blitzed by the number of adult patients that have used this therapy, and also by the number of publications that have come through for adult ECMO utilization. I was relieved, however, that there are still plenty of studies that I've got to talk about this afternoon when I looked it up on PubMed as we started the preparation. The number of studies have steadily increased for paediatric ECMO use over time, and although these don't hit the heady heights of the adult populations, there are kind of 280 to 400 studies per year. What I'm going to spend most of my time talking about today, though, are the prospective studies that are being funded by important national organisations. These are the NIH reporter studies, but there are international studies also being funded, and these are going to change the face of paediatric ECMO moving forward. Some of these studies are actually just the baseline consensus. Where do we start research in this space for the paediatric population if we want to build and do prospective studies? This is a consensus conference series that was funded by the NIH. It's not specific to ECMO, it's the taxicab study, Control and Avoidance of Bleeding in the Paediatric Population. But they actually had a subgroup specifically looking at the cardiopulmonary bypass and ECMO population. They included implementation scientists as part of this modified Delphi process to be sure that any recommendations that they moved forward could actually be incorporated into clinical practice. And that's something that we've done as we've moved forward with other consensus finding projects. This is one that I share with Dr. Mazinski, the Pediatric ECMO Anticoagulation Collaborative. And our lofty goals were to try and develop evidence-informed consensus statements for the management of anticoagulation of critically ill infants. But probably the most important part of the project has ended up being defining the research priorities as we move forward in this space and leveraging the network of people that have come together. You can see many of the subgroup chairs on the slide to be able to really move forward as a community. Neurodevelopment and neurological complications are forever on our minds with paediatric ECMO. And many of you will know Dr. Bembia, who's been moving forward with her BEAM study, the biomarkers in paediatric ECMO observational study, expecting to complete in a couple of years. More recently, Dr. Lakshmi Raman and colleagues have been funded for quantitative optical tools to continuously monitor cerebral autoregulation, including blood flow, oxygenation, and inflammation. All of these studies will be presented at some stage over the next couple of days, so you can look for them on your agenda for more information. Dr. Anne-Marie McGuarrian and the collaborators in the Canadian Critical Care Trials Network are looking at brain and ECMO outcomes as well, but this time particularly with reference to the way we manage carotid artery reconstruction at the end of ECMO runs. Many small children are still managed with VA ECMO cannulation, even sometimes for respiratory support. And the debates that happen at these meetings are often surrounding whether to reconstruct or to ligate those vessels. Hopefully these studies will start to inform. Dr. Bhargava has already been mentioned many times today, but he's established a prospective observational study, the ASCEND trial, looking at ARDS in children and ECMO initiation strategies and the impact on neurodevelopment. This is a really innovative study that is seated alongside an interventional mechanical ventilation study, the PROSPECT study, with data collected within the ELSO registry. So he's leveraging all of his many strengths to get this done. Despite the pandemic, he's continued with study enrolment, with more than 105 children enrolled from 90 sites from all over the world, with a study expected completion date with 500 patients by 2026. I should have mentioned that I have very few results from the Pediatric ECMO research talk, but I really want to share how exciting it is to be in this space of funded studies for pediatric research. And the next 3 studies that I'm going to talk about are all actually interventional studies for the population, looking at how we can improve care. So the first is the ecstatic study. This is an ECMO hemostatic transfusions protocol looking at populations of children who are supported on ECMO anytime 0 to 18 years in any ICU and VA or VV cannulation. They're funded now for a pilot study, And the idea of that is to make sure that within this population, we can actually randomise, that people are comfortable randomising to a liberal versus a restricted platelet transfusion strategy, and to use EFIC for one of the first times in the paediatric interventional study. So there's been no previous RCTs on this in ECMO in children. They're using an adaptive trial design to try and reduce the study size required, and they're using exemption from informed consent with deferred consent within the first 24 hours. And so we're really watching this within the paediatric community. 5 centres are signed up, and we're expecting 50 patients to be enrolled. The second prospective interventional study in paediatric ECMO that's been funded as we stand here is the Hydrogen FAST study. Dr. John Keir and Lynn Sleeper have been funded by the NIH for a feasibility study to look at hydrogen gas piped through the ECMO circuit in order to reduce neurological and renal injury post cardiopulmonary arrest. This will be mainly a paediatric cardiac population enrolled, and only at 2 centres, Texas Children's and Boston Children's Hospital for a start. But having done the translational science work and proven safety in adults with the gas, they've now been funded, for a randomised controlled trial of using this innovative therapy. At the same time, this is a picture from yesterday, which was our kickoff meeting for the investigators of the TIDA trial, which is a Department of Defence study of transfusion practices in paediatrics. So this is the trial of indication-based transfusion of red cells in ECMO. Dr. Ravi Thiagarajan has been working on this trial for a number of years, and when pairing with Dr. Jane Newberger and Dr. Lynn Sleeper, they've got the perfect team together. You can see many of us there as either site PIs or on the clinical coordinating team or data coordinating centre, and we're really excited to launch it yesterday. The innovation within this interventional study is basically that the transfusion strategy as the interventional arm is not just a threshold, it's an indication-based arm. And patients are transfused for bleeding, for inadequate oxygen delivery to tissues, or otherwise until they reach a much lower threshold than we would usually be comfortable with in children. There's also an innovative trial endpoint with the P-SOFA score looking at markers of organ dysfunction before ECMO and whether or not patients recover that function during the ECMO run. It means that we'll be able to get complete capture of data by the time patients leave hospital, but we also have a primary neurodevelopmental follow-up endpoint at 12 months to make sure we're not missing negative consequences. So with so much largesse and so much excitement in the paediatric community at the moment, there's also complications of so many interventional trials being funded at the same time. We're still a small population. We're all looking at randomising between 50 and 228 patients over the course of the time point, but most centres still don't have a lot of patients that meet criteria. And as such, we're at risk of missing the opportunity to include patients in trials or not co-enrolling trials because there's concern for negative consequences for each of the studies. Against that background, the Centres of Excellence in Regulatory Science and Innovation, the FDA CERSI collaborations, specifically the collaboration at UCSF Stanford, have piloted a modified Delphi process where we looked at what a framework for an adaptive platform trial would look like in the paediatric ECMO population. To be completely transparent, this is a mainly paediatric cardiac population with collaborators with the FDA as well as well-known established trialists and some patient representatives and perfusionists. But we looked at the paediatric ECMO population to see what meaningful questions we thought would be worth answering if we could stack them up together. This is the start of a framework that we're still brainstorming through. You can see that unlike many of the individual randomized control trials, what we're thinking about is that in an adaptive platform study, we'd be able to include all ECMO patients, any ECMO patients that meet the pediatric criteria. And for the FDA, that's less than 21 years. Clearly, there'd need to be stratification around risk factors for poor outcome. So we've considered respiratory versus cardiac or cardiopulmonary bypass, post-cardiopulmonary bypass patients, and elective cannulation versus cannulation that occurs during CPR. You can also see that we'd brainstormed a few different domains of potential therapeutic strategies, including anticoagulation, red cell transfusion strategies, and sedation. But we'd also like to collect data on ECMO circuit components that are used, in the same way that we find that that's so important within the ELSO registry. We'd expect a global endpoint for all of the arms to be the functional status score or some construct of the functional status score, because that's a meaningful patient-centered outcome. And we'd expect that as we received results from the early parts of the study, that the platform would adapt with adjustments to randomization ratio. A stable platform trial would both allow new questions to be asked of the same population without the build and rebuild of each individual randomized control trial, but it would also mean that patients can contribute to answering multiple questions with the same ECMO run. And with all of that being said, PD ECMO is on this evening at the ELSO meeting, and this is the end of my co-chairship with Dr. Todd Kilbar, who I'm sure is here, and we'll announce the new co-chairs this evening at the PD ECMO meeting if any of you would like to join us, and you'll be able to hear a lot more detail about all of the studies that we've discussed. Thank you so much.
Great, thanks for that terrific lecture. So my pleasure now to introduce Dr. Bart Griffiths. He's the Thomas and Alice Maria Hales Distinguished Professor of Transplant Surgery from University of Maryland, Baltimore campus. Welcome.
Does anybody need to get up and stretch? It's been a long run, and it's been a delightful one. I wanted to thank the organizers for inviting me, and particularly for the master, who I have followed now for more than 44 years, and I learn something every time he speaks. Thank you, Bob, for being Bob. My topic today is a little off-kilter, but it is about pushing boundaries, and I think it's about not vain excesses in terms of celebratory dances for what will be a long haul. I'm going to try and tell a very long story in 10 minutes. So if you were to begin a program and want to start thinking about animal parts for humans, and you sewed a pig heart, which looks a little bit like a human heart, actually a lot like a human heart anatomically, into an abdomen of a baboon, and expected that to work, you would end up with a picture that is shown on the right side of this slide, which is basically a heart that becomes necrotic in about 20 minutes. It does so because it undergoes acute rejection, which is in the early moments really about thrombosis. It's about poor control of coagulation, recognition of a xenoantigen, antibody recognition, complement activation, infarct, black organ. So how in the world do we go from this to considering an animal heart or an animal lung or an animal pancreas or other animal organs for humans? And it's through the marvels, really, of genetic engineering. And let's see the forward mark. How do we go forward here, kids? There. Okay. So the animal's heart that I placed into David Bennett a while ago had 10 genetic edits. There were 4 edits in which carbohydrate moieties on the surface of the endothelium were removed. A growth hormone kind of producing gene was removed, and then there were additional added genes which helped to control the coagulation system, which is off kilter relative to humans, and also an anti-inflammatory gene was added. This all started in our laboratories about 6 years ago when Mohammed Mohideen joined us. He was working tirelessly in the field of xenotransplantation, and rather anonymously, I might add, at the NIH. His big breakthrough was really his ability to maintain a pig's heart in a baboon's abdomen for more than 3 years. And he did that with the hookup as shown here. And this, those of you who understand this work knows that this is a live heart, but it's not a working heart. It's being perfused by the abdominal aorta, and it's draining basically its venous effluent into the IVC. But it's a good traditional way to look at immune suppression, and it's very commonly done in rats for the development of new drugs. It was also used in Mohideen's laboratory to test different immune suppressive aspects along with additions of gene edits. So the drug that seemed to make the big difference was an anti-CD40, which controls B cell rejection. Now, most of us in the transplant world for allotransplant know it's really all about the T cell regulation. Well, you flip the switch for xenotransplantation because it appears to be more of an antibody-mediated problem than a T cell one. So if you don't control the antibodies, you're going to have trouble. So just like cyclosporin and tacrolimus controls T cell activation, the anti-CD40 is a great drug, never before we used it, used in a human, but it seemed to work well in these baboon implants. So what does that look like? So this is the picture of an animal that has a beating pig heart. This is a baboon's shaved stomach. You can see it kind of pulsating there. That's what it looks like. You go and you make rounds on your patient and you feel the abdomen. If it's beating, you figure, okay, it's not rejected. So that went on for 784 days in this particular animal at the time of this picture. This animal was permitted to go more than 3 years, and then the decision was made, well, what would happen if we stopped that anti-CD40? Because we have a genetically altered heart, maybe we won't need immune suppression in a classic sense. The anti-CD40 was stopped, and within 3 weeks, they lost the heart. So 3 years, stopped it, 3 weeks later, it was gone. So it obviously was still working its magic on the xeno protection. And this is what it looks like now in our laboratory on the left. It was important to demonstrate that not only could you do an implant in the abdomen, but very important if you could translate that into a human-type transplant where you would remove the baboon's heart, implant the pig's heart, as has been done in this picture, into the baboon, and see whether or not it would provide life-sustaining function for a longer period of time, 6 months to a year. Well, it's shown here coming off bypass, firing away. It looks like any other transplanted heart. Really, you couldn't tell whether this was a pig heart or not. The anatomy is pretty close. And this is a 23-kilogram baboon, and it's received a 20-kilogram pig heart. You can see on the right, this is our ICU, if you wish, for the baboons, and this animal required a lot of medication, not exactly an outstanding success, and this animal passed away at 48 hours. In fact, we were almost out of business, and it reminds me of lots of the hard work early on that most of us have seen. We've seen actually more heartache than heartwhelming outcomes in our laboratories, but that's what has driven us. The translation to orthotopic life-sustaining heart was tough. We had between I guess it was a total of 16 cases between 11/17 and 8/19, and it's about $750,000 a case. When you add up the cost of the genetically engineered animal and the baboons and the animal care, and of course the big surgeon's fee, it comes up to about $12.7 million for those 16 cases, and only 3 lived more than 2 days. Well, our sponsor, which was United Therapeutics, was getting a little nervous. They felt that perhaps we weren't the right bet. About the same time, a letter was published by our German colleagues, and Bruno Reichart, known to a lot of our European investigators that are here today, but worldwide in xenotransplantation and allotransplantation. That team in Munich was able to put the pedal to the metal and get animals to survive. And this demonstrated a number of animals that had made 3 months. Well, to us in Maryland, when this came out, this was a miracle. It made us feel kind of meek because we couldn't do it, but we found out what their secret sauce was. And it was all about the use of a non-ischemic preservation method for these pig hearts called ex vivo. Basically, we had tried to duplicate how we take care of human hearts. We take them out carefully, we put them in ice, and we transplant them as quickly as we can. That didn't seem to work for us, didn't work for the Germans, and it wasn't until they switched over to a non-ischemic preservation system using an ex vivo perfusion system were they able to convert the situation into better outcomes, as did we learn to do. We jumped on a plane, got to Sweden pretty quickly, and went to Iglosa, which is where Dr. Stig Steen has done his work and has demonstrated, that his device could be useful to the Germans. This is a picture of basically a pig heart, genetically engineered, that's being dropped into the ex vivo system that's not easy to see, but there's that well, and it's covered up with a sterile dressing. But this, in fact, is a rather historic picture because this was the picture of the pig heart that went into David Bennett. And this is the team removing the pig heart. And that happens to be a postdoc, an MD postdoc, getting his PhD in xenotransplantation in our laboratory, Corbin Gorich, who's helping to do, in fact, did the explant. So anybody want to do a lot of work, come on over to Maryland. We'll put you to work, and you'll do some pretty important stuff. We had a patient that could not wean from ECMO. He'd been on ECMO for 48 days. He'd been hospitalized for 61 days flat on his back. His white blood cell count was not robust and ultimately went up and down when he saw a new antibiotic or got a new infection. It would fall. His platelet count seemed to be deficient. He had striking sarcopenia. Sarcopenia means lack of muscle. I had to learn that word. It's a good one. His left lower leg is shown there, and that's my size 7 glove hand around his lower leg. It was really tragic how disabled he was. He didn't want to die, and he said, "Is there anything you can do?" And I got the crazy idea that perhaps we had done enough in our lab with a 9-month survivor and now consistent 6-month surviving baboons without rejection, that maybe we could go ahead. We petitioned the FDA. We got it done. It was a fairly traditional operation, and you can see that this is a pretty fantastic looking heart, the way it's contracting. This, I think, was maybe on day 23, something like that. The upper part of this screen is what's called a stress echo. It shows beautiful contraction and would be the kind of allotransplantation you would dream of and don't often get early after transplantation. It was stunning, actually, that this heart was doing so well. It never saw an inotrope postoperatively. We had lots of complications, infections, low white cell counts, lots of antibiotics. He was probably on continuous antibiotics. But the heart was a rock star. It really was amazing. And everybody kept pushing us to do endomyocardial biopsy, and we were terrified. He had low platelet count. We didn't want to have bleeding. And he was doing great. Why do a biopsy? We finally did a biopsy. Our cardiologist twisted our arms. We couldn't take it anymore. This man was so sick, Derek, hi. That's Chris Wells, who came from our shop in Pittsburgh 22 years ago when I left to join us for physical therapy. But she's helping David hold his head up. He was so weak. I mean, this is almost one of the first times he had been semi-vertical. Great humanity and great empathy was shown to David, and he was treated like royalty because of what his commitment to the experiment was. The young lady behind is one of the nurses that went to our laboratory to take care of our animals in the evening after the first post-op day. So it was a nice team approach. This was the biopsy. We finally, gave in, got the biopsy. This was a 34-day biopsy. And when I saw this biopsy, and I assume some of you do heart transplantation or have talked about it, that's a biopsy that's about as normal as you can get. I didn't find one inflammatory infiltrate. None of the blood vessels looked like the endothelium was aggravated or ready to reject. I was so excited, I ran around and showed my bosses this biopsy, and I have a lot of bosses these days. It took me all afternoon to track them all down, but I was so excited, it was like, this was a tincture of youth. I mean, I felt great, this was wonderful. We have this patient, and he's not rejecting, and he has a pig's heart. Yeah, he had a pig's heart. I'd go home and tell my wife, I can't believe it. I'm sitting on the side of this man's bed and talking to him. Denny, I said, dear, he's got a pig's heart. And she looked at me, she said, yeah, you put it in there. Yeah, she said, I know that. I heard it on the news. So I'm trying to show, I want to draw this to a close because I know that it's late. But this was a kind of the high point where we were so optimistic. And I show a graphic slide imported into that slide, into that biopsy, which shows a blue, a red, and a green. The green is tropomyosin, basically. Troponin that's coming out of the heart cell. That's measured in hearts. If you have a heart attack, that green line goes up because you leak that into the cells from myocyte necrosis. The blue is IgG and the red is IgM, and those are antibodies that are anti-pig antibodies. So those are measured specifically against this cloned pig. We would measure these antibodies against endothelium that we grew in the lab. So we knew exactly that these were antibodies focused on those epitopes. And so we were going in the right direction here. Everything looked good. The anti-human pig antibodies were low. They weren't going up. Biopsy looked good. And the muscle weakness or the cleansing of the heart after implant seems to be quieting down. The heart's happy. Well, didn't seem to stay that way. You can see what's happened to this wonderful nadir where after one, which is the first biopsy, you can see that green line's rising. We're leaking enzymes from the heart muscle, and that usually suggests some trauma or ischemia. We're doing echoes all along the way. It looks great. And I'm saying, forget it. Doesn't mean anything. It's probably just, I don't know what it is. And it wasn't until the blue started to get really scratchy out there around 50, and we started to see human anti-pig antibody begin to show up, both of the IgG and IgM class. At this point, about day 43, it was a Saturday morning, he looked like he was having sepsis. He looked a little clammy, his blood pressure was a little low, he didn't feel very good, and he was close to being reintubated. We measured his circulating IgG, and those in the audience that take care of critically ill people know that that's about a tenth normal. So we gave him IVIG to supplement it because we thought he was dying of an infection and wouldn't be around the next day. The problem with that decision is IVIG comes from pooled samples. And guess what we're all exposed to, and guess what all of us in the audience have? That's right, anti-pig antibodies. So we gave him a bucket full of anti-pig antibodies, which confused the interpretation of the blue and the red. Were those de novo antibodies that we had given, or were they antibodies, his own, that we didn't give, or were they antibodies that we gave to him by supplementing his IVIG? So hard to know for sure. We were in a black box, didn't really understand. And of course, all these results are coming back a week later. You can't just send it to the lab and say, what's the anti-human anti-pig human antibody count, right? They look at you like you're nuts. So we had to go to the lab and grow these things. So it took a while, but we're putting it all back together now, what was happening, in fact. So then here, we saw that he was worse. He got a little bit better after that first sepsis-like syndrome, and he was back in a chair and looked pretty good. Actually, we were talking about where we're going to rehab him, and then all of a sudden he got sick again, and we gave him pheresis now, thinking that it must be rejection, has to be rejection. We don't know what's going on, but overnight his heart thickened and maybe got 4 times as thick as it was the day before, and he went into acute diastolic heart failure, meaning his heart couldn't relax enough to fill. It was squeezing, but it couldn't fill. Well, another little thing we had been watching that I haven't told you about yet that you might know something of was the presence of a PCMV virus. PCMV is actually a herpes virus. It's in the porcine class of animals, and it's what I call a hitchhiker. It can get in an organ, hang out, just like your cold sore virus does, right? Doesn't happen, it doesn't come out until you're in a windy storm or it's cold or other things happen to you physiologically that changes your immunity, and all of a sudden you blossom with a lip ulcer. Well, it causes a deep injury when it activates, right? So it goes from being non-active to active. And you can see we can measure, and we had been measuring in the blood the presence of this DNA, free DNA of this virus. And these are spectacular assays where you can measure free DNA of any bug, you know, and we just happened to be following all of the ones we thought might affect our patient. It had bumped up a little bit, but then it went nuts. It went nuts when he got really sick, around day 50. It went really high. We were able to hammer him hard with antiviral then, but that was against a white cell count that was less than 3,000, and all the antivirals are really difficult on the bone marrow. So we were struggling all along with our bone marrow and antiviral therapy all along. You can see we kept changing our doses of antivirals. And finally, I think we did get it under control, and you can see that the DNA molecules dropped finally after we got him on a very, very potent antiviral called aciditavir. On the left, post-op day 19 is a traditional echocardiogram where you're looking at the short axis. That's the left ventricle below, the right ventricle above. It's squeezing like the rock star that I mentioned. After he had had that first sepsis episode, the heart began to change. And you can see it looks a little different, looks a little thicker, and it's not squeezing as well. And it's undergoing this process of acute diastolic heart failure. Well, he got so sick, we put him on ECMO for the last 7 days of his life because his heart just couldn't keep up. And we thought maybe with pheresis we could reverse this process, and we hammered him with all the antivirals. His family, and that's his son, who he had been estranged to for more than 5 years before the transplant brought him together, brought the whole family together and made him very happy. They helped him make a decision to kind of let life pass, and so we pulled back on our support, and he did then pass away. I have the recording of him actually passing, but that's a little modeling for this morning. His next biopsy, day 50, before he passed, again showed no evidence of rejection. So we have a xeno heart functioning beautifully with no evidence of rejection until something, I think, very virally related happened. And the reason I think that, and here's the heart, it just blew up on us, okay? So that used to be a beautiful little heart, and I've never seen anything like this. This happened in 24 hours, and I liken it to when you turn your ankle on a curb, and your ankle swells. From the time you last looked at your ankle, it's now giant. That's what happened to this heart. This heart had an injury that affected its blood vessels and permitted a massive leak of fluid into it. And I'll put that together for you in just 1 minute. But the biopsy doesn't show any rejection. Everybody's betting rejection on this thing, right? Of course he rejected. He put a pig's heart in a patient. Well, we finally got to the source of the problem, and it wasn't easy. Again, he had about 10 days of really high antiviral therapy, and remember that the viral DNA had dropped. We were getting ahead of it. But unfortunately, the damage had been done. There's a picture on the autopsy overlay. This is in situ hybridization picture where we're looking at a couple of viruses here that are active. And you can see viral RNA present in those pictures. And you can also notice in the picture of the one up or on the right, that's kind of the bigger one, it's sitting right in a capillary. And that's where this virus hangs out. It hangs out in the capillaries of the heart. And when it activated, it blew up the capillaries. I have wonderful EM pictures of the capillaries just lysing. And I think what happened to this man on that day 50 was he just had insufficient integrity of his capillaries, and it just caused a massive swelling of his interstitium. And finally, that swelling interfered with perfusion, and loss of capillaries interfered with perfusion, and that's how we lost the muscle cells, and that's why we lost contraction, and that's why the troponin kept coming out now. So I think it was something that we missed. I think it was something that we can prevent in the future. We're going to keep digging for the cause of death. The relative roles of iatrogenic use of IVIG, we're going to rethink that hard the next time, but we're going to avoid taking a patient as sick as this gentleman, so we maybe don't have to face that issue. PCMV is likely the cause. Acute antibody-mediated rejection, I don't think so. We have no evidence of that. We now have a better screening tool for the latent virus to exclude it from the pig in the beginning. If we don't transplant it with the heart, the patient won't get it. Donor animal care is also changing to avoid cross-infection. These animals have their children, if you wish, under cesarean section. The baby's moved to another barn that's absolutely clean, and that will be how the commercial hearts are raised. I have written to the FDA for permission to proceed with one more case and to see how that goes. There is a plan for multi-center FDA trials of xeno heart transplantation that will probably not start till 2024. And in the meantime, we're going to have to go an expanded access or compassionate use based upon our laboratory experience. I hope they'll listen to us. We've learned a ton on the first one. Dave had a chance to help. He said if he didn't make it, I'm sure we would learn a lot. That said, on Dave's entrance into the operating room that morning, he looked at me and he said, "You sure I can't get a human heart?" And I keep remembering that. He's still in my mind. Anyhow, thank you so very much, and I hope we can get back and talk to you about this later.
So thank you for an absolutely extraordinary presentation. And with this, I'm going to wrap up this amazing plenary. We've been from 50 years previously. We've looked at children, adults, hearts, lungs, humans, and not humans. Who knows what we're going to be hearing about 50 years from now when we're hearing what we were doing today. So 50 years from now, I won't be here, but some of us may be. I'd like to thank the extraordinary speakers. I get a sense that here at this meeting, we are amongst pioneers. We're amongst the people who are setting the agenda for the future, and it's completely inspirational. So thank you to the speakers, thanks to my co-chair, and I'd also actually thank the organisers of this amazing plenary session. It's been an absolute privilege to be here. Enjoy the rest of the Congress. It's going to be fantastic. Thank you.